Thanks everyone for joining. We're going to get started in just a minute.
Welcome, everyone. And while everyone's still trickling in, we want to welcome you today to the final session of the 2026 Health Center Preparedness and Response Forum, which is hosted by the National Training and Technical Assistance Partners today. And we're going to be covering their focus of patient support. So we're glad that you're here with us today, and we're gonna go into a couple of housekeeping items, which I'm sure that everyone is familiar with Zoom by now, but we'll go over some details just in case. All participants are muted on entry, so if you which this means that you don't have camera or audio on. If you want to participate, you can do so via the chat. And I see a lot of you are doing so right now, so that's great. You can enter anything you feel like throughout the presentation in the chat, as well as send us any Q&A in the Q&A box. All questions and answers uh, will be taken at the end after the presentation is done. So we encourage you to participate that way. For any access needs, please message the host or panelists in the chat and we can help you, as well as knowing that this will be a recorded webinar and we'll email the materials to participants within 1 week. Also, please don't forget to fill out the evaluation form at the end of today's presentation. We value your feedback a lot and it helps us improve. So just as a session overview, this is the fourth and final session of this year's Health Center Emergency Preparedness and Response Forum. If you were not able to join us during the previous three sessions and would like to view any of the recordings, let us know and we can share those links directly. So you can send us an email and we can forward you those missing sessions you had. Uh, this forum is a collaboration across 11 different national training and technical assistance partners, or also known as NTAPs. NTAPs are funded to provide free learning opportunities to support health centers in a manner that increases patient safety and health outcomes to effectively serve health center populations. This particular group of NTAPs has been collaborating in this forum for several years now, and with today's session actually being the last of not only our annual sessions but also of the forum as it is currently structured. So if you would like to know additional information on any of the NTAP partners, we'll be happy to share any direct website links to in the chat. So just let us know. For today, we have a group of us facilitating today the session, and we have Austin Puka, who is the senior program manager of the Corporation of Supportive Housing, and we have Ariel Matter, who is the senior program manager of the National Center for Equitable Care for Elders, and myself, Maria Bustamante, I am the Health Initiatives Manager for the National Center for Farm Worker Health. So we're really happy to have you here today, and also with us is Juliet Provost, who's supporting the chat and helping us throughout the session as well. So today's agenda, we're doing welcome introductions. We're gonna be doing some level setting around patient support, which will cover individual, community, mapping and as well as effective communication. And we'll be going over some lessons in rural disaster response for which we have a guest speaker from Frontera Health with us today. So she'll be sharing some additional insights and the evaluation close. So with that, I'm going to pass it over to Ariel, who's going to continue the presentation today session.
Thank you so much. Hi, everyone. Really glad to see you here and so many folks introducing themselves in the chat. I'm feeling kind of emotional today because this is our final session. We've been doing this for quite some time, but I'm glad to be with you all today. We have some level setting to do before we turn it over to our wonderful guest speaker. And these three learning objectives kind of follow the three little sub bullet points you saw on the agenda slide. We're hoping that you can walk away with some insights about how we can strengthen patient support before, during, and after emergencies, and then expanding to the community, trying to better understand what's out there and building effective partnerships. And then shared strategies for effective communication. And of course, we get to also walk away with some lessons learned today from a health center. Go to the next slide. Great. All right. So before we dive into any strategies, it helps to ground ourselves in why the topic of patient supports during an emergency requires such intentional planning in the first place. So when an emergency hits, the needs that surface tend to fall into recognizable patterns, and understanding those patterns is what allows health centers to prepare thoughtfully rather than just simply react. The first pattern is access-based needs. These are the practical things that every person requires in order to benefit from emergency resources. So this is information they can find and understand, a place to go, a way to get there, their medications, and connection to services. When any one of those pieces is missing, the rest of the support system may not reach them all. And the second is function-based needs. Some individuals may experience limitations, whether that's physical, cognitive, sensory, or otherwise, that affect what they need and how they need it at any point before, during, or after an emergency. These needs aren't always visible and they aren't always the same from one emergency to the next. Next slide. Great. One framework that helps health centers think through the full range of patient needs in an emergency is CMIST. It gives us a practical way to organize our planning and make sure we're not overlooking needs that might otherwise fall through the cracks. So I'll walk us through briefly each part of this acronym. The C stands for communication. This covers really a wide range of ways that people receive and understand information, including those who need plain language, which is really all of us, in formats other than print or through channels other than traditional media. During an emergency, making sure your messaging is reaching and making sense to everyone is the starting point for everything else. M stands for maintaining health. So this refers to ongoing health needs that don't pause because an emergency is happening. So medications, medical equipment, treatments, and care routines that people depend on to stay stable. For many patients, a disruption here can escalate quickly. So continuity of care planning is critical. I stands for independence. So some individuals rely on support systems, maybe it's people or tools, to manage daily life, and emergencies can disrupt those supports significantly. This category prompts us to think about what happens when a caregiver is unavailable, a device loses power, or a service is suspended. S stands for support and safety. This recognizes that people have the right to make informed decisions about their own safety, and that our role is to support that versus override it. It also reminds us to think about patients who might be at heightened risk in an emergency situation and ensure they have what they need to make those choices. And finally, T stands for transportation. Access to evacuation, shelter, medical care, and services often comes down to whether or not someone can get there. Transportation is one of the most concrete and common points where patient support can break down during an emergency, and it's worth mapping carefully in your planning. What's really useful about CMIST is the way it works across all phases of an emergency. You can apply it to pre-crisis planning, your active response, or your recovery efforts. This framework can serve as a helpful checklist for making sure your efforts are as comprehensive as possible. So the way that on the next slide, the way we structured the learning objectives, you can kind of see that reflected here. We kind of have these three buckets where we're going to be talking today around improving patient supports and what that can look like. So it might look like patient care mapping to help visualize key people and services involved in a patient's life. Could be the broader community asset mapping to identify resources and address gaps. And then using universal precautions to simplify messaging for all patients. So starting with individual preparedness, the more prepared individuals are before an emergency, of course, the more effectively health centers can support them during and after one. So individual preparedness and organizational preparedness work best when they're built together. A patient's personal emergency plan should account for a few key things. You can see them on the slide, but really wanting to explore who is in their support network, those are the people that they can call on when something happens. How might they manage their medications, including storage requirements that might be affected by a power outage or displacement? Thinking about some of the things we just discussed in the CMIST framework. What about assistive devices or equipment that depends on electricity? Do we have a backup plan? Then considering, are there pets or a service animal whose needs need to be factored in? And then how will they get to where they need to go if their usual transportation is not available? So these are the practical details that determine whether a patient can follow through on an emergency plan when the moment comes. I'm sure a lot of you are familiar already with all of the great resources uh, on ready.gov. This flyer on the slide is one of them. I will, yes, to the questions in the chat around slides. We will follow up with the slide deck. Everyone who registered for this series will follow up within the week with these slides. So ready.gov has a ton of great resources for all sorts of patient populations, all different forms of communication. So I encourage you to check that out. All right, but on the next slide, when we're talking specifically around mapping when it comes to patients, I want to talk a little bit about care mapping. So this is a flexible patient-focused tool for visualizing and documenting a patient support network. So who's in their life, what role each person or place plays, and how those relationships are connected. It's designed to capture both the big picture and the finer details of how care actually flows around an individual because it evolves over time and it remains useful well beyond a single encounter. So a care map starts simply. It's just a drawing. It can be done by hand. It can also be done on a computer with the patient in the center. So from there, the inner circles capture the people and places most closely involved in their care, while additional circles can indicate distance. That might be categories of connection or both. Arrows show the direction that care flows. And as you can see in the little legend here, the line, weight, and style can communicate how frequent or strong the relationship is. And you'll see that some are bidirectional. Ideally, the patient is drawing this themselves, but it can also be created collaboratively with a provider or care team member. But in the context of emergency preparedness, care mapping becomes a particularly powerful tool. It helps health centers understand both who a patient has around them and where there might be opportunities to strengthen that network before an emergency occurs. A little bit more context on the next slide about care mapping. So the first step in drawing a care map is really about drawing that picture, asking questions that help identify who's in someone's life, both geographically and socially, and how these relationships function when it comes to giving and receiving support. So the questions in the left-hand column are designed to guide that conversation. Once the care map is drawn, the reflection questions on the right give the patient and care team a chance to look at it together and think more deeply about what it shows. So how is the support currently flowing? Where might there be those opportunities to strengthen or supplement? And what resources from either the health center or community might be worth connecting this patient to? Taken together, the drawing and the reflection process is really designed to support something that matters a great deal in emergency preparedness, and that's clear communication, stronger care coordination, and a shared understanding of what matters most to each patient. And if you want to dive a little deeper into care mapping, there's a link on this slide and now in the chat. Thank you, Juliet, to a full care mapping guide from the Atlas of Caregiving. But on the next slide, just as care mapping helps us understand support at the individual level, resource mapping brings that same intentionality to the community level. That's where we're going to shift our focus now. So a good starting point in understanding what disaster planning already exists in your community and how well it accounts for the full range of patient needs your health center serves. In many cases, plans are already in place. The goal isn't to start from scratch, but to understand what's there, identify where your patients fit into it, and determine whether or where rather your health center might play a role in strengthening it. So no single person or organization has a complete picture, complete understanding of what a community needs during a disaster or what it already has to offer. So building a network of stakeholders, so people with deep knowledge of your community, your patient populations, and local emergency planning is really essential. That network becomes your intelligence on both what exists and what might need to be developed or strengthened. So part of that work is taking stock of the skills, the services, and the capacity that are already represented across your community. So understanding what your network can offer and where there could be opportunities to expand it puts you in a much stronger position to support patients when an emergency occurs. And once those relationships are built, maintaining them certainly takes consistent effort. Ongoing communication across a planning network can be challenging given everything organizations are already managing. One practical approach is simply making sure emergency preparedness has a standing place on the agenda of community and partner meetings. Keeping it visible helps keep those partnerships active and the information flowing. So on the next slide, we have the table on the left giving us a practical tool for organizing what exists in the community already. So sorting resources into categories like emergency services, healthcare, social organizations, and neighborhood resources. This kind of structured inventory is the foundation of effective community asset mapping. But in addition to talking about what already exists in a community, it's worth pausing on a broader question, which is really what do people actually need from their communities in order to be well? And that's where the second framework on this slide comes in. The vital conditions for health and well-being, developed by the Ripple Foundation, offers a way of thinking about the conditions that all people need in order to thrive. It encompasses both physical necessities and those harder to quantify factors like belonging and civil engagement. So when we're mapping community assets and asking whether emergency preparedness and response resources are reaching all patients, the vital conditions framework gives us a comprehensive lens for that assessment. It helps us to think not just about what services exist, but whether the full range of what people need to be well is represented and what might need strengthening. So on the next slide, asset mapping tells us what exists in a community, but the real work of emergency preparedness happens through the relationships built around those assets. So when we think about who belongs at the table for emergency preparedness planning, partners tend to fall into three kind of broad categories. So the public sector, local, county, federal health departments and emergency management agencies. These bring regulatory authority and coordination infrastructure, whereas private sector, which includes utilities, businesses, critical infrastructure owners, controls many of the systems that communities depend on when an emergency hits. And then community and nonprofit organizations often have the deepest trust and the most direct relationships with people your health center serves. So each of these partner types brings something different to the table, and a strong preparedness network draws on all three of them. The second column here is equally as important because not all partnerships look the same. It really can exist on a spectrum. So at the foundational level, it might simply mean sharing information and building mutual awareness of what each organization does. From there, partnerships can grow into voluntary coordination, where organizations recognize each other's roles and begin to align their efforts. Deeper still is operational collaboration, where partners are actively working together in planning and response. And at the most integrated level, organizations are functioning as part of a regional alliance. They have shared systems, shared protocols, and shared accountability. But the takeaway I want to emphasize here is you don't need fully integrated partnerships across the board to do meaningful preparedness work. What matters is knowing where each relationship currently sits on that spectrum and being intentional about where you want it to go. So the next slide, we'll shift to our kind of third bucket around improving patient understanding. So when we think about supporting patients through an emergency, so before, during, and after, how we communicate is just as important as what we communicate. Health literacy is really the foundation of that. So let's make sure we're working from a shared understanding. You can see on the slide that Healthy People 2030 actually gives us two definitions that work together. And I think both are critical for us to understand in this context. So the first is personal health literacy. So the degree to which individuals have the ability to find, understand, and use information and services to inform their health related decisions and actions for themselves and others. So this isn't just about reading ability, it's about finding information, understanding it, and then actually being able to use it to make decisions. That's a much more complex skill set than we sometimes give it credit for. The second definition focuses on our role as healthcare organizations. So, organizational health literacy is defined as the degree to which organizations enable individuals to find, understand, and use information and services to inform their health related decisions and actions for themselves and others. So, really, here, the word that we want to focus on is enable. So, this definition puts responsibility on us as a system. It's not just about whether our patients understand, it's about whether we're creating an environment that makes understanding possible. These definitions work hand in hand. We can't just focus on one side of the equation. So, yes, patients bring varying levels of literacy and health knowledge to the table, but we also really have tremendous power to either support or hinder their ability to navigate their health, which, for the purpose of today's session, is really preparing for, responding to, and recovering from an emergency event. On the next slide, one of the most important frameworks for thinking about health literacy in practice is the concept of universal precautions. And if you're familiar with this in the context of infection control, the logic's very similar. So with universal precautions for health literacy, we assume that all patients may have difficulty understanding health information and accessing health services. So, not some patients, not patients who look like, quote unquote, they might struggle, truly all patients. Because we can't accurately assess someone's health literacy just by looking at them. Education level doesn't predict it, age doesn't predict it. Even folks with advanced degrees can struggle with health literacy if they're stressed, if they're sick, if they're dealing with an unfamiliar condition, or navigating a complex system. And shame often prevents people from revealing when or what they don't understand. And if that's true on a regular day at your health center, consider how much more true it becomes during an emergency. Stress, fear, uncertainty don't improve anybody's ability to process information. It makes it harder. The patients you're trying to reach are often dealing with all of those things at once. So instead of trying to identify which patients need extra support, we design everything with clarity in mind from the start. When we use universal precautions, we remove the guesswork and the potential for misconceptions. We want to create an environment where clear communication is the default and not the exception. So on the next slide, have a little visual of the CDC's crisis and emergency risk communication framework. This recognizes that really communication is not necessarily a one size fits all across an emergency event. Different moments call for different approaches, and the CIRC rhythm maps that out across 4 phases. The first being the preparation phase. This is the work that happens before an emergency occurs. It's when health centers, of course, have the most time and bandwidth to prepare, building relationships, developing materials, and making sure patients know where to turn when something does happen. But this is also when preparedness messaging tends to be hardest to land because the urgency isn't yet felt. The second is the initial phase, the early moments of an emergency when information is probably still incomplete, but the need for communication is immediate. So the priority here is acknowledging what's happening, being honest about what isn't known yet, and helping people take action with the information that is available. So clarity and speed matter more than comprehensiveness at that stage. The third is the maintenance phase. So, as the situation stabilizes somewhat, communication shifts toward keeping people informed, correcting misinformation, and sustaining trust. This is often where health centers are doing a lot of hands on patient outreach and coordination work. And the fourth is the resolution or the recovery phase. Once the immediate event has passed, communication turns to helping patients and communities understand what comes next, what resources are available, and how to reconnect with care. This phase can last a lot longer than many people expect it to, and it often requires just as much intentionality as the phases before it. So when we talk about reaching and understanding patients, understanding what's available in our communities, and refining our messaging, considering where we are in this rhythm can help shape what will actually be effective. And now we get to move from concept, from theory to application through the insights from our wonderful Health Center guest speaker. We can go to the next slide. I'll just quickly introduce her and then let her give more context in her presentation. But Rosanna Roberson is a strategy director at Frontera Healthcare Network, a rural healthcare organization located in Texas. She leads initiatives that strengthen access to care, expand services, and support long-term organizational growth. So we are so pleased that she's here with us today to talk about some lessons learned. Thank you so much, Rosanna. I will hand it over to you.
Thank you. I appreciate it. Next slide, please. So today I'm going to share our real world experience responding to recent disasters in rural Texas, specifically what we learned, what did not work, and how these lessons have helped to reshare our approach to preparedness and response. Next slide, please. So a little bit about us and who we are. Frontera Healthcare Network is a federally qualified health center, commonly referred to as a FQHC. We serve a large rural region in central Texas, approximately a little bit over 6,200 square miles. We operate 5 clinics, a behavioral health clinic, 6 school-based clinics, and an in-house pharmacy. And we serve approximately 8,600 patients annually. For many of the communities we serve, we're not just a provider, we are the only accessible healthcare option. Many patients in our rural service area have to travel over 40 miles to see another federally qualified health center that is not operated by Frontera or even to see a specialist provider. Next slide, please. In our rural communities, disaster response looks different. We face many challenges and barriers, such as geographic isolation, limited infrastructure, transportation barriers. Our workforce is limited, and communication systems are not always reliable, even on a good weather day. So when a disaster happens, it doesn't just delay care, it can actually eliminate access to care entirely. Next slide, please. So I'd like to now share with you a little bit about what we experienced during the July 2025 flooding disaster that hit our service area. Counties in our area in certain locations received 10 to 12 inches of rainfall in a very short period. It led to 136 swift water rescues in Menard County. The San Saba River in Menard County, to give you a little more context, it's typically crested about 3 feet. It rose to 17 feet. There is a hollow in Menard County that typically runs dry, and within just a few hours of the rain coming down so quickly, the hollow swelled to the size of 4 city blocks. There were actually cars swept off of roads. There was very significant road damage, making it hard for first responders to reach residents because the roads and the low water crossings were completely underwater. And then to further complicate matters, as we were in the midst of deploying resources following the flooding taking place on July 4th, July 6th, Menard County had a secondary flooding event, which further complicated matters and caused additional damage. Next slide, please. So our staff were not only, stepping in to fill the gaps and responding to the floods, they were also victims. So we had staff and patients directly impacted. Infrastructure and access was severely disrupted. Patients lost their homes, resulting in being displaced across the region. We even had one of our staff members lose their home was an entire loss. And we had several staff members that had damage and loss and that were temporarily displaced, which put us in a constant response mode. And as I'll get into this more, but at the time we did not have a structured system, and we were just, very reactive. Next slide, please. So gaps that we identified and what we were facing. We had a constant response, but it wasn't structured. We did not have a good system in place. We quickly started to identify major gaps. We had no structured way to identify and reach high-risk patients at the time. Our communication internally was fragmented. For example, we had supervisors that did not have the direct contact information for their teams and their direct reports outside of we use Microsoft Teams and Outlook. And so they didn't have, for example, like their personal phone numbers to be able to reach them. At the time, we also only had one community health worker who had just recently submitted her resignation right before the flooding. So, covering a 6 county service area and then being down our only community health worker was cut us pretty short. And then our community engagement navigators who do help with resource connection, but not quite at the level of our community health worker and being that involved, they stepped in and did really incredible work. But they were learning in real time and learning how to navigate FEMA applications, how to replace medications for patients that lost their medications during the flooding, and then helping patients access, any other resources they needed without formal training. Another thing that was slow to deploy was the FEMA disaster recovery centers. It took about a month to get established in Menard and then in McCullough County. So Frontera just stepped in and led the charge and became the front line for helping residents access assistance. We set up recovery areas. We set up resource stations to deploy hygiene kits and some basic first aid kits, other, just essential supplies and food during the initial response. Next slide, please. So as we were responding in action, our adaptation also happened in real time. Once we started to identify the gaps, we we realized we needed to get out to the victims and quickly. And so we reached out to neighboring health centers and we were able to borrow two mobile medical units and deployed medical and behavioral health staff on each unit to meet patients where they were, and which included hotels and housing, temporary housing set up for displaced residents. We established mental health support centers and resource navigation hubs for both flood victims and first responders. We discovered, that the first responders really needed some support as well, and the things that they saw and were dealing with and working around the clock long hours, and that was very important to help support them as well. At the same time, we quickly built some county-specific resource list for all of the communities we served, and it was kind of a directory page that we were passing out throughout the communities, sending out with our mobile medical units and at the disaster recovery centers that we set up. And these lists included available shelters, food resources, medical services, and then assistant programs. And we were helping to connect individuals to that. This helped to bring a little bit of structure and consistency to how we were guiding patients to resources. And then we partnered with AmeriCares and International Medical Corps and Texas A&M University, who helped to send staff members to help us to fill in staffing gaps and um, to help deploy. We were mucking out houses. We were, like I said, providing medical and behavioral health support, and then just guiding they also helped us to guide our response efforts and helped us to get better workflows in place in real time. And then we also were working very hard to provide behavioral health support for our staff because we recognized that our team needed support as well in order to continue serving others. So our team, we weren't just responding, we were surviving the disaster all together. Next slide, please. So the response, like I said, revealed many gaps in our workflows and in our systems. And this drove us to really take a hard look at our approach and to really move from being in a reactive state to a more structured state. And this has helped us tremendously as we are planning for future disasters and we conducted an after action review. And then we've kind of seen this we haven't had luckily another major disaster, but we did have an ice storm here in Texas. And for those of you in southern states, we just don't lack the infrastructure to handle ice storms. So Texas kind of gets shut down. And just seeing these changes in real time play out with the flooding and the disaster response, we were in such a reactive state. It took days to get our units mobilized and out. And then during the ice storm in January, we were able to move so much more quickly. And our approach is now completely different. Before, we were not running the high risk patient reports and contacting those patients and calling them to see what they need, and going to their house. Now we have workflows in place and staff are assigned to run the high risk patient reports and then contact those individuals. We had more reactive ad hoc outreach, and we're just out in the communities trying to knock on doors, go to homes and find people. And now we have a more proactive and structured approach with how we handle that. We lacked EMS coordination workflow. Now we are been working more closely with our county officials and our EMS coordination workflows. They are still in development, and we have a few more trainings scheduled over the summer, but we are going to do some live trainings and role plays to practice for future disaster events. And that's becoming much more coordinated as well. And then, like I said, it previously had taken us days, and then now we are prepared to mobilize because of the structure and the systems we put in place into the same day. Next slide, please. So what we learned shaped how we lead today. We look at the gaps through four lenses. And we have gaps, strengths, weaknesses, and opportunities. And then we built our systems from there. As we came out of the flood response, we were very intentional on reflecting on what happened. We looked at where things slowed down, where communication broke, where decisions weren't clear, and then where patients were falling through the cracks. At the same time, we looked at our strengths as well and how adaptable our team was and stepping into roles like our communication navigators, filling in and helping to fill in for the community health worker. Our um, strong commitment to the community is another one of our strengths. And then looking at our weaknesses more directly, lack of structure, lack of formal workflows, and limited preparedness for navigating disasters. And then this has led us to identify opportunities for improvement, strengthening communication, formalizing our partnerships and our workflows to collaborate and leverage strengths across our rural counties so that we're not duplicating our efforts and everyone is using their strengths to the best that they can. If I were to give advice to anybody as they're working through their disaster planning, based on our lived experience, I would say don't wait until after the disaster to start figuring out your systems, to have those systems in place and that structure before the event. And then just as importantly, make sure to conduct an after action review afterwards and then pause and reflect for real improvement for the next disaster because it's not if, it's always, when it's going to happen and just being prepared. Next slide, please. So building long-term capacity. So silver lining out of the flooding. Like I said, we borrowed two mobile medical units from partners and deployed those two units out into the community. And now we have a mobile unit that we have coming next month that we're really excited for that was grant funded so that we will be able to respond faster, being independent and having our own mobile medical unit to deploy. We are working with external partners to do some workforce training and preparedness. So our staff are trained before crisis and not in the middle of one and having to learn things in real time the next time around. Our mass communication systems, we are working to build out more reliable systems for rapid internal and community communication. And then our community partner alignment. We are formalizing partnerships across health, emergency, and community organizations and getting MMUs and assigning roles. So we have clear swim lanes as to who is doing what when it comes to disaster response and then outreach. We're trying to really strengthen those systems so that preparedness is not just a plan or not just trying to ad hoc, throw things around. It's a coordinated system and we are ready for the next time around. So that next, sorry, that concludes my presentation now.
Wonderful. Thank you so much, Rosanna. We have plenty of time for questions, which is great. I have a couple of questions of my own, but I see we have a question in the chat. Is there a strategic partnership between regions that correlate post-incident response findings to establish a collaborative best practice to respond to emerging crises? I guess reflecting on unfamiliarity with regional dissemination of best practices happening in real time. I don't know, that seems like more of a general question, but is there anything, Rosanna, that comes to mind for you as far as what you've seen, like more in that regional sense?
We've been working with TDM, some for some further emergency preparedness and more collaboration. But being in small towns and small counties, for us, it's been more on the local level versus like a regional, but we are, if one of our counties has a great idea, we share that with the other county judge and an EMS and disaster response coordinator if they have one, because some of our towns are so small, they don't even have a disaster response coordinator on staff.
Yeah, thank you for that. We have a question around software programs. Is there a particular one that you've identified that can help improve the communication among staff?
Yes, so we recently started to use Salesforce, and we have added the marketing communication cloud, and we are working to build out that system further and make sure that all staff members are enrolled in the program so that we can utilize the SMS texting features to send out mass communications to our staff members so that they're safe. If, because some of them were flooded in during this disaster. And they couldn't travel in. So just making sure everyone um, was in the know.
Yeah, no, thank you for that. I know that I had briefly mentioned in the level setting um, that we did around, pre any emergency happening, how it can be a little tricky because there's not like a sense of urgency. Maybe that's felt among patients when thinking about, steps they might need to take. As you all have learned so many great lessons and thinking about how you all are structuring communication going forward, do you have any ideas around the best ways to communicate with patients, prior to an extreme weather event? So before anything else hits your area, what are your thoughts on how how Frontera is able to reach patients effectively?
Yes, and you mentioned this some in your presentation earlier. We realized like during flooding events, patients the way they process the information is differently. So we've really been trying to put better communication in place. Before we've been utilizing Care Message, and that's a text message platform with our patients to prepare them and send out information and getting our patient base enrolled within that platform to receive the messages. We've also added a resource tab on our website, and our resource list for each of the counties are listed on there, so patients can access them there as well. Of course, we use social media to send out messaging and weather awareness when we have forecasted bad weather coming, and then putting flyers in our clinics, running reports for our high-risk patient population, and sending out reminders and having staff assigned to call them to make sure that they fill their medications ahead of time and they have everything that they need, at home in case they are stuck at home for a few days.
Yeah, absolutely. No, thank you for that. We have a question around, obviously you'll have the reference point, Rosanna, for Texas, but a question around, are there any state level support to increase the number of mobile units or upgrade the ones that are currently available in certain cities?
Yes, so the rural health transformation funds, have been released, and Texas currently has several of the initiatives open. Applications are open right now, and there is initiative 6 is specifically for equipment purchases, and that's been a state initiative right now. To Mobile medical units are an allowable expense, so if someone needs to add that to their health center. That was one way, a state-led initiative anyways, to get that type of infrastructure built.
Great. So we still have a little bit of time. I'll hand it over to Maria in a moment just to wrap us up. But I did wonder, Rosanna, so you all have again learned so many lessons and there's been some pain points, but now you have a better sense of how Frontera is going to move forward. Um, for anyone who's here today who might not yet have as, robust of a plan, who might, it might resonate with them where y'all were before, these flooding events happen. Is there anything, is there a first step that you would encourage folks to take? Or is there, if someone is not coming from a location that has a lot of that programming in place or the plans in place, is there something that someone could start to do today or this week or this month that could really make a big difference in the long run?
Absolutely. As first steps, I recommend just to start establishing relationships with your county officials and your elected officials and making them aware of, what your organization can offer and just in ways you can collaborate, especially in our rural areas where resources are so limited. It is very important that we're not competing or not duplicative with our resources, and just those relationships aren't a muscle that you can develop, in the moment. You need to have ahead of time. And something else that we have started and we're in actually our third year of is we have established stakeholder teams consisting of county officials, um, members from the school. If there is another health provider in the area, they're invited. Our local chambers, and then any other nonprofits, faith-based groups in the communities. And we actually meet monthly, and we were able to secure a grant to help to fund this. And we meet monthly over lunch and just building those relationships so that when disaster strikes or when any community problems arise, for that example, I mean, some really beautiful things have come out of our stakeholder groups, not even related to the disasters. In Menard County, for example, we were able to build a green space. We lacked a green public space with playground equipment for children to play, and our stakeholder teams were able to collaborate and get that developed. So, um, just having those partnerships in place is just really, really critical.
Amazing. Thank you for that. I know we have a question in the chat around maybe other states, and certainly not a question for you, Rosanna, but I'm curious if any of our NTAP partners want to put any resources in the chat. I'm not familiar myself if there's perhaps there's a place, a one-stop shop you can go to identify what initiatives might be available in your states, but maybe someone can put a link in the chat for that. Before I hand it over to Maria to wrap us up, I just want to thank you again, Rosanna, for your time today and for sharing your insights. And it's really fantastic that you all have, gone through some difficult things and being able to take that and ensure that the right things are in place for any future emergencies. And we just really appreciate your willingness to share.
Thank you. Thank you again for having me.
Thank you. All
Thank
right.
you both for the great presentation. This has been a great experience for us as NTAP partners. So being able to deliver the sessions to you every year. So we greatly appreciate your assistance to this. And there's going to be some season, session resources available. Remember, the slides and the recording is going to be sent out to you a week from now. So watch out for that email so that you can have the recording available. And if you have any other needs, you can reply. If you want past sessions as well, you can reply to that email so that you can get the additional information you need. Also, feel free to reach out to each of the NTAPs. We continue to provide additional training and technical assistance to health centers and other organizations. So we greatly appreciate you filling out the evaluation that's going to come out at the end. And we appreciate you taking the time to complete that. And on behalf of all the NTAPs that we're together in this forum, we appreciate your participation. And with that, I think that we conclude today's session. Thank you for everyone's participation and constantly supporting the work that we all do in the NTAPs to support the health centers and the patients that you serve. So continue to do the great job that you all do, and we're sure that we're gonna be able to continue supporting you as well. So thank you.
Thanks, everyone. Whether this is your first forum session or you've been with us for many years, thank you for joining us, and we hope to see you again soon through another activity. So thank you all. Have a wonderful rest of your day.